Thank you very much. And what an act to follow. I'm following the Queen. Thank you very much to the organizers for having me back for a second year. I thought I got off last year, but you wanted me to come back, so I'm back this year. We're going to spend some time looking at side effects of treatment, and I'm so pleased that Fatima mentioned quite a lot of what I think is very important is what is important to you, what matters to you, and that is the key. And as Marina said, for me, your voice is super important because you matter the most. And so hopefully, if you take nothing out of my session, is to hopefully encourage you, empower you to say, speak up, and talk to us about your side effects so that we can better support you in your day-to-day. So we thought we would just focus on a few of the side effects because there's too many side effects. And so this year, what we're going to do is talk about 4 of the main side effects. Hopefully, we have some time at the end to ask me any other questions. I'm happy to take any questions. Nothing is off the cups for me. So the first one is nausea and vomiting. And I think it's important one to talk about because we also know it can be quite debilitating. And I wanted to start off by saying you are not alone. And you are not powerless either, because there are things that we can do about nausea and vomiting. It's one of the side effects that affects the majority of patients going through treatment, and it's because it's associated with a wide range of the treatments that we use. And I've just given just a few selection here about chemotherapy, endocrine therapy, analgesia. But I think the most important message in there is that nausea and vomiting, it's not just about the discomfort that you get when you feel it, but it's the effect that it can also have on you, the individual, in terms of affecting your nutrition, affecting your mood, affecting your strength, your ability to even get on with your day-to-day activities. Because if you're feeling really uncomfortable and just can't even look the sight of food or touch food, that is horrible. And that shouldn't be when we are in a decade where we can better manage this sort of side effects. There are different types of nausea and vomiting that we also need to acknowledge. And that we have acute nausea, and this is often where it happens almost immediately, within 24 hours of you having your treatment, you feel that sense of nausea. And there's delayed nausea, which can come further on. There is anticipatory nausea. So when you feel that you're worried about going to have your treatment, what that can have on you, and you are worried about it. So that anticipation, anxiety, can sometimes cause nausea for some people. And then there's breakthrough, where it happens even when you've taken your anti-sickness medication and you still feel nausea. And then there's refractory, which is just persistent. It's just there, and you're doing what you're told or what you can, but doesn't seem to really get on top of it for you. Now, as healthcare professionals, we often like to grade things so that we can hopefully better manage it. But I think the important thing is that what is a grade 1 or low risk for somebody might not be the same for another person. So this is not to say that if you're having a treatment which in the healthcare professional's eyes may come under a low grade or low risk, doesn't necessarily mean to say that you have to take that as the gospel, because that treatment might affect you more than somebody else having exactly the same medication. But there are some drugs that we know have got a very high risk of causing nausea or vomiting. And normally with those treatments, you will have quite a number of drugs that will be prescribed or advised for you to take with that treatment. And I've just given a few examples of those. So again, this is not just the gospel. This is just some examples of the medications that we can use to treat some of those or to prescribe for somebody having those class of medication. So there are drugs that are classified as grade 4 emetic, so it will cause more nausea or vomiting. And you might have some of these medications prescribed for you to take with that medication. But beside medication, there are also what we call complementary therapies that can also be really helpful when you're managing nausea or vomiting. So things like sometimes doing things like small and bland meals that can be really helpful, and not trying to have a whole meal or sit down to have a whole portion of food. Ginger or peppermint tea, some people swear by it, that can be really, really useful in terms of managing nausea or vomiting. Deep breathing or guided imagery can actually also help some people with managing or controlling their nausea or vomiting. Acupressure wristbands, and so if you have complementary therapy services at your hospital or maybe at a charity close by, often they might be able to support you with these pressure bands, which are also quite useful. And then sometimes avoiding strong smells can actually be, some people can get set off by strong smells, so they might want to avoid that. And in terms of coping with anticipatory nausea, you can do things like calming rituals. So you may find things that actually really help you to feel calm, to feel relaxed, to actually be able to get into a different headspace. That can really help with managing that. And aromatherapy as well. We can also talk to support groups, talking to people about it, sometimes sharing how you feel can be really powerful. And then key is being consistent in routines before your session. So trying to maintain that consistency, if it's helping you, if it's giving you the control you need, is really, really important. So I'm a nurse. I like to give people things to take home. So I've got take-home messages. And I think my take-home message from this is that please be honest about your symptoms. As Fatima said, sometimes the treatment we give, they are quite high doses. It doesn't mean to say that that will work for you. So tell your healthcare team if it's affecting you in a certain way. Talk about your side effects with your team. Don't try and hide it or try to be strong and fight it. And people say, I just want to keep going and be strong for myself and don't want to feel like a failure. You are not a failure. This is not your fault. This is the fault of the treatment. So talking about it, getting help with it, isn't a failure at all. And ask about pre-treatment medications. If you need to have something before you go into the hospital, it's really important. I think having a toolkit is always good, so you know what works for you. Write down what works for you, what gets you the better control over your symptoms. And have some kind of comfort strategies that you're going to have. But also, who's going to be your support? Who's going to be the person that's going to help you through those days when you don't feel very good about yourself? Who are you going to fall onto? So have that support network set up as well to help you. The next one is often a bit of the elephant in the room that nobody talks about, but most people suffer with: fatigue. Now, fatigue is not just you feeling tired, and it's feeling exhausted, feeling like you've just haven't got the energy at all to do anything. And somebody described it as, it feels like walking through wet cement. Now, I haven't walked through a wet cement before, but I can imagine how that might be. I've got very little legs, so I don't think I'll probably come out of that wet cement if I'm in there. And this is how that somebody feels. And I can just imagine how debilitating this can be for that person. It's the most common and most misunderstood side effect of cancer treatment, unfortunately. But what we have found, and I brought this from breast cancer now, there are a number of things that can affect or influence cancer-related fatigue. And some of it can be the cancer itself, the treatment, but other conditions as well, and sometimes the treatment effect. It can also be due to things like dehydration, depression, or low mood. Stress or anxiety can be crippling to the point of making you feel you've got no energy to do anything. And lack of sleep, which is often a real big issue for a lot of people when you're worried and you're anxious about things that are happening, family issues, work issues, all sorts of things coming at you. But there is help. So what can help? What can you do? I think it's about making small changes that will often make the biggest impact. So start small. Start small. Keep a diary of what helps you. Rest before you feel tired or you feel drained. Sometimes I describe it to patients like, treat your body the way you treat your mobile phone. When you're fully charged, you use it. When the battery is low, put it aside, plug it in, recharge it. And that's how I kind of feel it's helping you to then manage that fatigue. Prioritize meaningful tasks. So you can use like a traffic light. Prioritize, what do you really need to get through today? What can you reasonably do today? What can wait for maybe another day or 2 or 3? And what can also go down that pile? Or somebody else can do that for you. You haven't got to complete everything by yourself. So having that priority then helps you to hopefully focus on what you've got to do, and you're not expending too much of your energy to get through everything in the same time, which will just kind of really get you down. Ask for help. Ask for help. We are all very bad at asking for help. Often we think that we're being burdensome onto our family, our friends, people around us, and so we try to sort of keep up with a bit of be stoic and try and get through everything ourselves. But ask for help. And also learn to say no. And I say that to myself as well. I don't say no to much things. Learn to say no. Today is not the day. I can't fix that thing for you. I can't do that thing for you. So say no. Put you first. Be selfish sometimes and put you first. But also, quite weirdly, physical activity is one of the best ways of managing fatigue. And it feels awful saying it, but it's the most important thing as well, because when you're tired, the last thing you want to think about is doing anything physically active. However, there's been lots of studies that have shown that actually movement helps. And so I've put there purposely movement, not marathons. Nobody's expecting you to run a marathon, but just movement, just getting up and moving, doing something is often really important and good for you. And you can also use apps now. There's lots of apps for everything. And there's a couple of apps that are very good. The entire Now app is a really useful app, and it's purposely designed to help manage fatigue. So you can download it, you can use it. That will help you in terms of managing fatigue. But your healthcare professionals have got a job here as well. And there are things that we can help you in terms of managing your fatigue. And so talk to your team. Treat if there is possible cause. There may be a reason why you're feeling that fatigue. You may be a bit anemic, you have low hemoglobin. So that might just need a little bit of a top-up. And that will give you the perk and the energy you need to be able to get on and do things. Or you might just be having a few other side effects that are related to your treatment. So once we can get on top of that, you feel a lot better in yourself to be able to get on and do things. So talk to your team about it. And sometimes they might need to adjust your treatment. We've talked about that. Dose reduction, dose adjustment is not a bad thing. It's about making sure that you have a good quality of life. And there may be a need for a multidisciplinary team approach here. So looking around for us to be able to see who else we need to bring on board to support you, like your physiotherapy team, like the occupational therapy team, or some counseling support to help you manage whatever else that we need to help manage with. And there's a Restore, which is the Macmillan Fatigue Management tool, which is really useful as well in helping you to manage. And there are also things like complementary therapies that might be helpful in just a bit of a pick-me-up to help you, give you a bit of a boost in your energy. And there are also local support and national groups that you can join. Because sometimes, I say that myself, going to the gym, getting up and going to the gym by myself is a really tough thing to do. It just doesn't come easy at anyone. But sometimes having somebody with you that can partner, that can get you that bit of energy can be really helpful. And this is why these groups are really useful in terms of helping to get you energized, but have that company as well to be able to go out and do things and enjoy what you're doing. And there's a lot of them around, so you can find something that's close within your community or local area that you can tag along. And my take-home message here is track your energy ups and downs. It's good to have some kind of an idea what you're doing. Know your recharge rituals. What are the go-to things? What helps you? It's one of my common questions in clinic I ask patients. What helps you? There's no point me telling you something that might not be useful for you. But if I know where your energies are, I can use that to then help you. So know what recharges you. Fuel for recovery. Eating well is helpful, and that will give you the energy you need. And that's not on fat. It's just eating well. Good, balanced diet. Stay connected with people. Listen to your body. But celebrate every win. If you were doing 10 minutes and you do 15 minutes, that's yay. Celebrate it. It's a win. So every little win, give yourself permission to say, I've done good today. And treat your body well. Use your healthcare team. They are there to help. Please speak to them. Use them. That's what they are there to do, so that they can help you to be able to manage better. And then we've got constipation and diarrhea. She brought the room down. But why do we have to focus on this? Again, constipation or diarrhea can really impact on people. It can really impact on you. It can affect your quality of life. It can lead to treatment being delayed or needing adjustment if it's not better managed or supported early on. But it can cause things like dehydration, imbalance in your electrolytes, and even hospitalization. And as we've heard earlier, we want to keep people well, hopefully away from the hospital. So if there's things that we can do to manage that better, that's the way to go. Constipation, I think I don't need to explain that, but I have to because I'm presenting it. It just means difficulty trying to have a poo or stool or bowel movement. And diarrhea means you're going the other way too many times. Now, we know that there's a number of treatments, again, that can cause this, like chemotherapy, targeted therapies, immunotherapy, analgesics, painkillers that we give. Anti-sickness medications can sometimes cause, some of it can cause constipation. Others might be because you're not being able to drink as much because you're feeling nauseous, so you're then drinking less. Or you just don't have the taste. Your mouth feels so uncomfortable that nothing tastes anything and you don't want to drink anything at all. So you're not drinking much, you're dehydrated. But also decreased physical activity, not moving much. Now I found this and I thought, oh gosh, how useful. Maybe I can share this. Because it's important to sometimes be able to visualize what it is that we mean, what it is that we are talking about. And so the team at St. George's in London have had this grading of what constipation is to try and help with managing patients who come to the door with them. And they describe grade 1 being that you haven't had a bowel movement in the last 24 hours. Now, that might be normal for somebody. That might be normal for you. But if that goes beyond your normal, what is normal for you, that is something of concern, and you may need to get some support with that. Grade 2 being 48 hours, you haven't been able to move your bowels. Grade 3 being 72 hours, and grade 4 being 96 hours. And this might require some real medical help to be able to get you through it. And it can cause a lot of pain and discomfort for people. So, what can we do? How do we manage this? We can do something preventative by taking things pre or ahead of time to help manage that. And that includes keeping hydrated, so drinking as much fluids, and I say fluids, not water. So fluids, and that can be tea, coffee, whatever you drink, that can help. Dietary fiber intake, making sure that your food is rich with that, can really help. And being physically active, keeping that little movement going can help. And then if you need medication, there are stool softeners and also laxatives. And this may be prescribed for you by your team, or you can have it over the counter as well. But it's important that whatever you're taking, please speak to your doctors, your team about it so you know what you're having and what you're not having. It's always important to do that. And also monitoring. So if you keep a track of how your bowels are, what is not happening that is out of your normal routine is always important. We know ourselves better than anybody else does. You know your body more than your doctor will ever get to know. So you know what is your normal and what is not normal for you. And adjust interventions promptly. So actually talking about it, getting help promptly is also really important from your team. Diarrhea, as I said earlier, is the opposite of constipation. Now, there are some specific treatments that can really cause diarrhea, and there are some treatments where we sort of bang on about it a bit because we know that it can really be debilitating for patients. It's often caused because you've got a bit of altered absorption due to the treatment or damage to your intestines or the lining of your gut and changes in your gut microbiota. So it's important to make sure that, again, you're listening to yourself and talking to your team about it early on. It can be graded from being mild to severe, and in severe cases, it can lead to dehydration and even hospitalization for some people. How can we manage? Again, it's important to make sure that in terms of practical and self-help tips, you're having good enough hydration and fluids. You're having good amounts of small diet that can help. Frequent meals, avoid high fiber or greasy meals or dairy foods that can often make your bowels move even more if you are having diarrhea. So if you start to notice diarrhea, you need to make sure that you're doing these little self-help practical things to try and manage that. You can also be given anti-diarrhea medications, and often you're prescribed this to take after each loose stool. Sometimes I've heard patients say, I took one this morning and I haven't taken one again, but they've been, in between that time, they've been 3 or 4 times. So it's important that you stick to the prescribed medication when you're giving the medication. Watch for signs of infection as well, because it could be as a result of something that's going on, which could be something like colitis, infection in the gut. And seek help, either from your medical team or from your primary healthcare team, depending on where you are with your treatment. Again, it's important that we have a multidisciplinary approach to managing this, and this can often include not just your oncologist, your nursing team, but also dietitians, because they may be able to give you advice about dietary advice that you may be able to use to help yourself in terms of those little self-help tips. And also pharmacists, to make sure that whatever you are taking is looked at in a very comprehensive way to see what else could be contributing to the diarrhea for you, what can be taken out, what can be changed for you to help you better manage that symptom or side effect. I promise you this is my last one. Again, we thought this is quite universal and important, so we will spend a little bit of time on it as well. Hair loss and thinning. And again, I don't have to say much because I think I'm preaching to the choir here. Hair loss is very common, or thinning is common with lots of breast cancer treatments that we give. We know that chemotherapy can affect the hair follicles and make them fall, and it's not just hair on your head, it's all body hair that one can lose. There are some targeted therapies as well that affect or cause hair loss or hair thinning. And radiotherapy, if it's delivered to certain parts of the body, like the brain or around the breast or under the arm, can also cause hair loss. But immunotherapy rarely causes hair loss, but some people still can experience hair thinning, which is just as difficult sometimes for some people if they can see that their hair is feeling quite light and much less as they know themselves to be. Endocrine therapy, we know that these can cause hair thinning, but it's difficult to say how common it is because often people are on it with other things as well, or on it for much longer. So it's difficult to always classify them. What is available? Hopefully, in most treatment centers, most hospitals, you have access to scalp cooling with lots of treatments. There are some treatments which might not be eligible for scalp cooling because it's not, may not be indicated for. But in most cancer hospitals or treatment centers, there will be scalp cooling. So if you haven't and you're about to go and have treatment, you can always ask about that. Do you have scalp cooling service here? So you know what's available to you. Now, we know that it can work for some people in that it may keep some of their hair. Unfortunately, for some people, they might still lose some hair or may have a bit of a bald patch under the crown, on the crown area. But it's sometimes definitely worth a try. And I always encourage people, just give it a try. If it doesn't work, you can stop it. If you don't like it, you can always stop it. There is wig support. And again, different trusts or units will have different services that are available. So again, talking to your team about what is available to you. You may have to go and have it fitted by somebody. You may have to pay an NHS prescription for it, or it may be part of the care and support you receive. And there are a number of them that are available. But also, often, I think with the NHS, it's more like acrylic hair, not human hair. But if you need something a bit more upmarket, then you may be able to access that as an additional service that you get. And there are also hair replacement support that specific salons or providers may have. These are called interlace hair replacements, where you may be able to have something really integrated into your own scalp. And I've just put a couple of those which are in London, I know, but I may not know if they are everywhere. But it's always worth sort of, doing a bit of homework about it. So Lucinda Ellery, Jennifer Effie, they do this hair replacement where you can get a bit of what's called interlace hair replacement. But these days, there are also a number of scarves and head wraps, some of which may have hairpiece at the front, so when you wear it, it makes you look like as if you got a head scarf with your own hair on, or even on the back as well. I've seen some with hair on the back, which is like a cap that you wear, and gives you an illusion of you having your own hair. So there are a lot of these that are available. And there are also charities that may offer support about how you look after your scalp, how you look after your wig, and may even help with cutting the wig or shaping the wig into a style that will fit you and make you feel more you. Again, I think it's important we talk about, like I said, it's not just hair on your head, hair on all body hair, which includes eyebrows. And so you can look at things like semi-permanent makeup, having microblading or micropigmentation done. I found that Boots, in partnership with Macmillan, have got this really useful support for makeup and wigs. You can have hair concealers, and there are a number of organizations that provide really useful support in terms of looking after your hair. And sometimes with hair thinning, you might just need to be able to see a trichologist if there may be some other cause for the hair thinning that can be corrected for you. So it's always good to sort of have that in mind as well. And really important to seek help. So it's a multidisciplinary approach. It's not just your oncologist, but looking at your clinical nurse specialist, other members of the team that may be helpful in terms of looking and supporting you. Endocrinology is really important, dermatology, so looking at you as a whole and looking at the team as a whole to support you. And there's also palliative care support for symptom management, psychological support. There's a lot of charities that are available, and I have got a list of other organizations here. All of them provide really good amounts of support for you whilst you are going through treatment, for you and your loved ones as well. So I know some of these are in London, but I think a lot of them provide national support. So no matter where you are, you can access the support from them.
So I'll just thank you so much, Sarah. That was comprehensive, and I thought hopefully very practical for everyone. So we'll start off with some questions from the floor. My apologies for those in Slido. The iPad wasn't loading up the questions, so they're just going to have a look now. So I will alternate questions from the floor and from Slido as well, if you're submitting questions. Any questions from the floor at the moment? So I've got a question. In terms of hair thinning with endocrine therapy, I think we underestimate how much hair is lost. And for some women, I've seen, because they can be on the on letrozole and CDK4/6 inhibitors for years, their hair is quite significantly thinned. And I have recommended things like Regain for Women. These are expensive options, but maybe supplements. Do you have any top tips for that? Because I can't see my way around how to help women in these positions.
I think you're absolutely right. It's quite difficult sometimes to be able to, like I said, it's a problem, but we don't know how common it is. But we have had a few who come through and will talk to us about it. I think first thing, what I say to people is looking at it from a multiple approach way. So looking at the diet. Diet is important. We do sometimes say people can try things like Regain, but we don't know how effective they are. And so that person might still wish to try. And I think the very one thing that we don't often say enough, but we should, is actually, is there any other cause? And so looking at things from maybe seeing a trichologist and having some blood tests, maybe assess and see whether there may be another reason why they may be experiencing the hair loss. But also even practical things like what hair product they may be using. It may be that somebody is used to a certain type of hair products and that's what their go-to is. But if they've changed things over time, they might just want to kind of start looking at taking things out, thinking of what has happened in that time that could potentially be accounting or impacting on that hair loss as well. Yeah.
And the other, sorry, we've got Slido working. Yeah. Oh, fabulous, great. So just a question, so I'll stop asking my questions. So I suffer from muscle cramps from my Phesgo treatment. I had bloods taken at various levels. Everything looks normal. Can you suggest anything else? Muscle cramps.
Muscle cramps? Oh. Tonic water?
Yeah, so I always...
I learned that from you.
Tonic, yeah.
Tonic water.
Tonic water. I say make sure that, so you can take some quinine. Well, I always say make sure that you do get blood tests because it may be to do with electrolyte imbalances. I think magnesium can sometimes help, magnesium supplements. So you just need to be careful, especially if you're on Vinaralbin, your magnesium can be low. So that's something to watch out for. And tonic. Sorry. Oh.
Cream. Magnesium can get in cream form, yeah.
I didn't know that.
Yeah. But I think if from this person's question, if they've had blood tests and nothing has been found to be the cause and there's no sort of electrolyte issues, then, yeah, maybe some quinine water.
Yeah, so tonic
water.
Maybe with a bit of gin. I don't know if I'm allowed to say. It's quite nice with a bit of gin, but there we are. But definitely, but hydration. Don't forget, hydration is very key. So we have a lady here in the audience, so if we could have the microphone there.
I was just going to say as well, Claritin or loratadine has always been recommended and does seem to work. And I've started sour cherry juice, which does seem to work as well. But my question was how sometimes you can actually identify what side effects are coming from what. Because I had a little break from my Phesgo recently, only 2 weeks, and it was lovely. But then I realised that a lot of what I was blaming on the hormone therapy was actually the Phesgo as well, like with the muscle and joint pain. And so sometimes it's very difficult to know what is doing what. And also, I wonder whether you do recommend to people to try different hormone therapies, because I was originally on letrozole, and again had terrible pains in my legs and stuff. I was quite scared to change it, but then I changed to anastrozole, and then my nausea that I was just putting up with completely went. It wasn't the reason why I changed. So it's like, it's being brave and having encouragement to change.
Yeah.
And not
Absolutely.
not everybody encourages you.
I think sometimes it's difficult for clinical teams to really understand, maybe unpick what is causing what. But that's where sometimes it comes down to then trying. Should we give a break to that, or should we stop this and then monitor to see what happens? And so sometimes treatment breaks are really important in working out what is causing what is it that we need to be looking at and managing. And I'm glad you said that. I think sometimes it can be quite anxiety-provoking when you're being asked to come off a drug or stop the drug or have a break to check and work out what is going on. But often it does help in terms of helping identify what we can help with.
I would just say with the endocrine therapy, sometimes it's just stopping and restarting after 4 to 6 weeks can make a huge difference.
Yeah.
I don't know if it's like a recalibration or what, but it does really help. You can switch between the aromatase inhibitors, letrozole and anastrozole, without too much difficulty, but you can't switch to exemestane because it often uses up another line of therapy. And in the early setting, we do switch between exemestane, letrozole and anastrozole a bit more freely. But in metastatic disease, it uses up, in terms of NHS funding, our ability to use everolimus exemestane later on. So that's why your oncologist may be reluctant to use it. Yeah. Oh, brands. Oh, no.
Oh, yeah.
Make sure they know brand. Not just changing the brand. Because remember, most drugs have got other chemicals in it.
I'm going to contradict you a bit, Carlos. So brand change, I think, can help, but don't go seeking for one particular brand. Just if you don't get on with a particular manufacturer, just mark it on your calendar, one to avoid, because you will go around in massive circles trying to get the manufacturer that really works for you. Yeah. Yeah.
Go back and they don't. So the issue is
It is definitely worth switching. I don't know if you all heard that. Carla was talking about having different manufacturers of the endocrine therapies that can really help with some of the side effects. And I agree with that completely.
We've got a hand up there. So
I'm in charge. Stop coming around down. Like, I've got something from Slido. We've only got a couple of minutes. So something from Slido just about menopausal side effects from therapy and why we're not linked into gynae teams. Actually, that's one of the topics we're going to talk about later. So please hold tight. We will address that.
Lovely.
So my question is in regards to palliative care. So I've been trying to get palliative care because prior to my diagnosis, I already had a bit of back issues, but it seems like it got worse. But then it's hard to be like, is this in the cancer category? As like, should it be the oncology team helping me, or should it be my GP? But there is no meet in the middle. So then, I asked for palliative care for those reasons, but my secondary cancer nurse said, no, start with paracetamol. But I've been there previous to my cancer diagnosis. So then now I'm just not taking anything because I don't have someone to meet me in the middle. So how would you, in terms of advice, if possible, what should I do when it comes to that? Keep advocating to get palliative care because they'll probably understand a bit better on how to help me managing, or just wing it because that's what I'm doing. I'm not taking anything.
Thank you very much for your question. Now, I think, like most services, it's fair to say palliative care teams along across the country are struggling sometimes, and we have had situations where we feel we need to refer somebody on to palliative care for them to just start to have a contact with them and to establish and to help support symptoms as and when they may come. And often we get a bit of a pushback because that person doesn't have symptoms that are needing to be managed at the time. I would absolutely encourage you to advocate and speak up to your team, your breast care nurse, and be specific about what the issues that you are having now so that they can help you make that clear in a referral to the palliative care team. Your GP can also refer you for palliative care. And again, I think it's really being very, very honest about what is going on for you that needs that support. You need that specialized support from community palliative care team. But yeah, I do appreciate it can be really challenging sometimes.
Thank you. We've actually come to our time for a break. I'm so sorry, I could see questions in the audience. It's just allow you...
Just to tell you, palliative care session tomorrow again, where that may come up.
Oh, sorry, yeah. So just to reiterate what Carla's just said, we have a palliative care session tomorrow with Dan, and hopefully he'll be able to address some of these points. I'm now going to bring this first part to a close, so you can all have a break and have a cup of tea, but please come back for 4 o'clock. Thank you very much.